much. So we changed a little bit the title because they asked me to include the vasodilator on top of the inotropes, and also focus in acute heart failure mainly. So you know that heart failure is a chronic disease, but actually have a bunch of decompensation. The more decompensation, so the progression of the disease is clear, and it's like acute events, actually. So the more decompensation you have, the worse is the prognosis. So that's why acute heart failure is something very important to target on. And if you look at the current treatment, suggested, this is from Dr. Mans, our colleague there at Duke. So when you have acute heart failure, you start with the high-dose loop diuretics, relieve symptoms, and everything is okay. You keep on heart failure medication chronically. If not, you add thiazide diuretics. It continues congestions. Then you consider vasodilators or ultrafiltration. And in hypotension, I mean, eventually you use inotropic therapy. So basically, it's a general consideration. You see, this is 2004, the ADHERE database, and actually, after many years, pretty much similar what's going on in acute heart failure. Mostly diuretics, some use of inotropes, some use of vasodilators. So it's been many years and not many new stuff to consider with. You see that acute heart failure is a killer of new medication or new compounds. You see that a bunch of medication tested, I mean, was having, the thing is, you have to consider that you may have a good response, I mean, you may feel better, but the thing is the clinical outcome. So always you have to focus on a clinical outcome. So the question is, using 24 or 48-hour medication can have an impact in the long-term follow-up. It's not like an acute MI. I mean, in acute MI, you give a PCI, primary PCI, or thrombolytics in the acute event, and then you have a change in the prognosis in the long term. Acute heart failure is different, and that's why probably there were many failures. You see, these are many medications that didn't work out well. Only 3 agents were approved in the last 2 decades. I mean, basically, mill-renowned nesiritide in the US, levosimendan in Europe. And the level of evidence in diuretic is pretty poor. Even nitrates have a B level, and none of the medications have a clear impact in the clinical outcome in the long term. And what could be the explanation for that? You see that in general, when you have acute heart failure, you have neurohormone activation with inflammatory activation as well, and dysfunction, microvascular dysfunction with hypoperfusion, and then you can have the end organ failure. But in order to understand why many failures in medication tests, it's divided between 2 phases. The phase is the very acute phase where you have the hemodynamics with pre-load, after-load, and decreased cardiac function and vasoconstriction. And then after 48 hours, you have the long-term, that is the activation and neurohormone activation, oxidative stress, inflammation, all the other factors that can affect the long-term follow-up. And that may explain some of the failure in the new medications. When we go to vasodilator, actually the one we use, I mean, is nitroglycerin, nesiritide, and nitroprusside are the 3 that typically, mostly, whenever we use mainly nitroglycerin. You see that the mechanism of action, typically, they have a very quick start. The half-life is very short in the 3 of them, and have a little bit different excretion. But the story, I mean, for example, with nesiritide, which is a vasodilator that was approved early in the 2000, the beauty of that it was initially the BMAC trial. They went to dyspnea score, I mean, a surrogate endpoint. And the dyspnea score improved compared with nitroglycerin. You see that the patient did much better with the deafness score. And the FDA went over and approved the Nasiritide. After a while, I mean, 2005, Sackner Bernstein put together the 3 trials and said, oh, looks, I mean, have higher mortality, Nasiritide compared to nitroglycerin. So that's, I mean, it's good for dyspnea score, but not for survival. So then it had to be the largest at that time acute heart failure study, which was the Ascens trial. I mean, many thousand patients. And actually, I mean, the results were equal. So there were no really benefit. You see the benefit from Nasiritide compared to nitroglycerin. So actually the FDA continues, but the use of Nasiritide decreased significantly, including that the cost is higher. I mean, it wasn't, the safety was reasonable, but I mean, the efficacy wasn't that good as was expected. The same happened with vasopressin antagonists, which actually is an aquaretic. It's a good idea. I mean, you see that you use diuretic, and the diuretic doesn't have really long-term clear clinical outcomes. But the aquaretic was really a good idea. I mean, there were initial studies that were very, very positive. And then when they did the big study, which was the Everest trial with tolvaptan, look at the clear lines. So currently, tolvaptan is safe, but it's not used, it wasn't approved for using in acute heart failure. I mean, sometimes you use for hyponatremia in patients with heart failure, but not in acute heart failure. Another number of new compounds were being tested with a newer mechanism. The natriuretic peptides, you have ularitide and candidatide, and then you have another like GMP activator like shiraniwat. So this was very promising, which is relaxin. Relaxin, you see that have a numerous mechanisms that improve, decrease inflammation, decrease fibrosis, increase vasodilation, have good renal effects, and improve angiogenesis. So it was very, very interesting concept. And when they did the first initial studies with relaxin, you see that the survival was very good. I mean, 5.6% compared with almost 10% with placebo. It was very promising, with some quality of life, like dyspnea score also was positive. And if you see when they combine the 2 studies, I mean the pre-relax and the relaxed acute heart failure study, was almost the same. There were a clear significant difference in survival. So based on this study, which was almost 1,100 patients, they I mean, created a new trial that was acute heart failure 2 study, which was a larger study, and see what happened. 6,000 patients, and there were no difference at all at 6 months follow-up. So serelaxin was another acute heart failure drug that didn't actually work. The other was roloxifene, which is an adenosine antagonist. That the idea was to focus on renal function. There were a good improvement in GFR, a normalized diuretic made a decline in GFR. So if you see that the roloxifene, I mean, they did the study, the PROTECT study, and again, the curves was completely exactly the same. So they were no different at all. So it was another medication that in acute heart failure couldn't be used. This was very promising as well, ularitide, in acute heart failure. Have a lot of good effects that was very promising, including that they improve, decrease the proBNP, decrease the troponin release. Through acute heart failure trial was done, and exactly the same curve. So ularitide is out there, so no longer in testing. The other that was a new compound was the bericiwat, which is a 1-LAC class stimulator, So also was promising, but for some reason they stopped the development. So the initial studies, and they decided not to continue in phase 3 studies. So that was kept out of the. Dr. Ferker from Duke as well, he started testing the TRV027, which is blocking of the angiotensin II type 1 receptor, which basically the idea was very good because, you know, angiotensin 1 was the wrong effect that it have in. So in a trial, in the BLAST acute heart failure trial that was tested different dose, I mean, also there were absolutely no difference you see in every aspect of acute heart failure. So they stopped also on this continuous development of this medication. So what happens when you have this? You are in this quadrant, which you have acute heart failure. You are wet because you have congestion, but also you are cold, so you have a low perfusion. That is the worst scenario. And also it's a worse scenario when you have elevated wedge pressure, but also you have elevated right atrial pressure. That means probably you have biventricular dysfunction. So this combination, cold and wet plus biventricular dysfunction, is the worst scenario. And that's where the inotrope or vasopressors are possibly used. You see that you have to differentiate clearly what are the inotropes and what are the vasopressors. So there are a bunch of inotropes that all of you know: dobutamine, milrinone, levosimendan, enoximon. And then there are also a number of vasopressors that are also very well known, which is norepinephrine, epinephrine, phenylephrine, dopamine, and vasopressin. So all these type of you use in different scenarios. Again, because you have to use it, there is no choice. Because in the clinical outcomes, there is no inotrope or vasopressor that have a clear. For example, you see dobutamine all on the wrong side, especially because of mainly the arrhythmias and some sort of hypotension. The same happened with milrinone. Milrinone in the early 2000, everybody in the United States using patient with acute heart failure put on milrinone, and there were no clear data on that. And so the Optime CHF trial was done in acute heart failure versus placebo, and basically the patient have more atrial fibrillation, 4.6 compared with 1.5 in control, and have more sustained hypotension. That's why this type of inotropes are called inodilators. So you have to be careful with the hypotension, in particular when the acute heart failure is significant. Dopamine in low dose, the idea in this study, they combine low dose dopamine with low dose diuretics compared with only high dose diuretics. And actually, there were similar outcomes, but was in the combination in the low dose dopamine plus low dose furosemide was improved renal function and potassium homeostasis. I mean, that combination in low dose is reasonable use. When you compare dopamine with norepinephrine, I mean, norepinephrine have some occasional benefit when you use as a vasopressor, not as a low dose. When you use high dose of dopamine, I mean, as a vasopressor, you have to use mostly norepinephrine. So the story of levosimendan is interesting because in Europe, they did a couple of studies. One was the LIDO trial. So it was a good idea of the medication because it increased the calcium in the cytosolics, but there were no arrhythmias associated with it. So they compared in the LIDO trial dobutamine compared with levosimendan with reasonable results. You see, the other study was the Rushland study. So in both the LIDO trial and the Rushland study, there were positive results in Europe. So you see, the LIDO was compared with dobutamine, and the rational was compared with placebo. So it was approved in Europe, but not in the US. In the US, there were a couple of more studies done. It was the survive and the revive studies, and actually there were no difference in those medications. So the FDA didn't approve that medication in the United States, so you don't have that available. Some in registries you can have combination in dilators plus an oppressor, and supposedly there is some sort of benefit when you combine them, because you avoid the vasodilator of the inodilators with the vasopressor. But again, I mean, you have to use the lower amount of inotropes you can use. I mean, that's the main idea, because all of them have some sort of complications. What happened with the new inotropes? This was the omecamtiv, so it was a myosin stimulator, and was also very promising. Dr. Tierling in San Francisco started the development, and they did the atomic acute heart failure trial, so there were no improvement in deafness score. So they stopped the development in acute heart failure, but they continued in chronic heart failure. So the cosmic heart failure was a good result, and then the phase 2 trial, the Galactic trial, is ongoing, and it's finishing probably to 2020 or 2021, depending on the enrollment rates that you have. The other new idea was istaroxime, which this was published by Georgiade in 2008. It was a good inotropes, have some benefits and different mechanism of action, so that's was a good idea to use. Has the isotropic property, improving diastolic relaxation, less arrhythmias. For some reason, Dr. Georgiade died a couple of years ago, but for some reason, after this publication in 2008, I mean, the drug was bought by an Italian company. They continue the development, but so far there is no clear information on how is the process of doing that. When you see cardiogenic shock, and you see the randomized study actually in cardiogenic shock, you see the only one, which is the SOAP-2 trial compared with dopamine, where norepinephrine is a better option. Lately, just recent published, it was the angiotensin II for the treatment of vasodilatory shock. Not actually for cardiogenic shock, it's for vasoplegia. I mean, patient low peripheral resistance. That is called Giapreza. FDA approved recently. It's a regional medication. To me, at some point, we want to start using in heart patient in cardiogenic shock or advanced heart failure when you have significant hypotension and have low vascular resistance, because many of our patients have low or normal low vascular resistance. So it may be an option in the future for this kind of medication. Again, you see that there is newer percutaneous assist devices that may be some option when you fail with inotropes. So when you combine 2 or more inotropes, I mean, the survival is not that good. There is a lot of evidence about that. Thank you very much for your attention.